Licensing, payer, and workflow blockers. That is the cost of treating a group practice to IOP or PHP conversion in Nevada as a simple service label change. In Nevada, the conversion runs through SAPTA certification, Medicaid Chapter 4100, commercial payer requirements, and HCQC facility licensing. If your practice already treats substance use disorders or clients who need more structure than weekly therapy, this expansion may be practical if you evaluate it as a regulated conversion. This guide covers the licensing questions, the staffing gaps, the location test, and the payer readiness to verify before you market the program. Here is the key. Do not go hunting for a standalone Nevada IOP or PHP license category. The real question is which requirements your exact site and service model trigger. SAPTA may matter for substance use treatment certification, public behavioral health participation, and program standards. Nevada Medicaid's Chapter 4100 governs substance use disorder treatment services and coverage. A separate HCQC health facility licensing issue may apply, depending on the exact site and service model. And commercial payer requirements round out the review. Get the threshold wrong and small assumptions become licensing, payer, or workflow blockers after a build-out, marketing campaign, or payer application has locked you into the model. A late space review can leave you locked into a location that may not fit the program's privacy, zoning, or supervision needs. And reimbursement does not automatically follow the service label. Provider enrollment and authorization have to be verified first. A group practice may already have an outpatient therapy EHR. Structured IOP and PHP programs usually need more. Behave Health's EHR, CRM, and RCM are designed to support the workflows structured programs need. That means admissions, group schedules, authorizations, and medical necessity documentation. Plus claims follow-up and reporting, the revenue cycle side of the conversion. And Behave Consulting helps operators pressure test the plan before assumptions become blockers. Before you market the program, work through 4 areas: licensing and certification, staffing, location, and payer readiness. Let's take them in order. Step 1. Resolve the licensing and certification question with the actual agencies. Start with the current HCQC health facility licensing page. HCQC moved to the Nevada Health Authority in July 2025. HCQC's alcohol and drug facility category is defined as residential treatment, so do not assume every outpatient conversion falls there. Check SAPTA, where substance use treatment certification is relevant, and review NRS 449 for statutory context. Step 2. Staffing and clinical leadership. A conversion is not just a schedule change. A structured program needs clinical leadership, substance use treatment expertise, and group programming, plus level of care review, documentation controls, utilization review, and discharge planning, and clear ownership of compliance and revenue cycle coordination. Step 3. Decide whether your current therapy office can actually support the program. Can the space support confidential group programming without privacy or flow problems for existing therapy clients? Does it align with accessibility, safety, zoning, fire, lease, and supervision needs? And would the site still make sense if a facility or certification review applies, rather than ordinary office assumptions? Step 4. Payer and billing readiness before you rely on the revenue model. Review Nevada Medicaid, Provider Enrollment, and MSM Chapter 4104 for substance use disorder treatment services and coverage. Verify medical necessity criteria, authorization review, and documentation expectations. Commercial contracts, credentialing, and denial management can determine whether the expansion is financially workable. For national context, review the outpatient billing code guides, then validate how those concepts apply to your Nevada model and payer mix. Behave Health's guides cover the H0015, H2036, S2010, and S9480 outpatient billing codes, plus the IOP level of care and PHP versus IOP. Treat them as context. Nevada-specific details still need direct verification. Use this as orientation, not a launch manual. Before you launch, verify the current Nevada path with the sources that can actually confirm it. HCQC, where facility licensing is relevant. SAPTA, where certification is relevant. And NRS 449. Nevada Medicaid materials, your commercial payers, and qualified counsel. Then, build the implementation plan around the program you actually intend to operate. Stop letting label change assumptions become licensing and payer blockers. Scope your Nevada conversion with Behave Health. Book a 20-minute demo at behavehealth.com. Talk with Behave Health before you market the service or commit capital. Book a demo at behavehealth.com.